thanking Dr. Gujral and all the organizers of this very nice program that has been going on for so many years. And before I actually begin, my heartfelt gratitude to Dr. Borges, because I know she was one of the people who began this program. And by keeping it going, I think we on our part are paying our tribute to this great lady. So thank you again. And today my talk will be on techniques, something which is not very interesting for as students, but very, very important, especially when you get on to practice. And I think as students, if you get involved in techniques, your life will be so much more easier. So as is said, as is our technique, so is our pathology. Now, in histopathology, unlike other branches of the laboratory medicine, we have very unique sort of challenges. The diagnosis, as we all know, is image-based. But to get to the image, there are several steps in processing, which is unlike radiology. Our samples that we received are a one-time sample, and they cannot be procured a second time, be it a brain biopsy, a tumor, or whatever else it is. So we need to be extra cautious about this and should keep that in our mind all the time. Many of these steps, even though they are automated, as you can see, still require a human intervention at every step, and that we need to keep in mind. It's extremely skilled work. So technicians who are good, technologists who are good, we need to nurture them. The time required at each step is directly proportional to the number of samples. So unlike biochemistry or even clinical path where they have batch analyzers, we don't have batch analyzers. We analyze every tissue individually, and so the more the tissue that you have, more the number of samples that you have, you need to proportion more time of yourself and of the technician. And this processing is very, very important, but because it directly impacts all the modern tests that we have in our armamentarium, including IHC, molecular testing, NGS, AI algorithm use, and so on. So if you don't process your tissue well, you have lost out on all these special tests. What are the important steps? So we will begin by receiving samples, and I'll quickly go through each of this. I will not be dealing with the details, but just to tell you what are the important things at each step for quality maintenance, and a little bit as to what are the advances in these areas. So we start with the receipt of samples when it reaches our lab, and then the fixation. Having fixed it, we gross it, then we process it in machines, then we do the cutting, the staining, the submission, on all of it, keeping in mind that we have a turnaround time. We need to maintain our turnaround times. Now, if you ask me what is the most important in all this, in my opinion, the most important is fixation. So coming to receipt of samples, you can have many ways by which you receive. What we have is, and I think most labs will have something called an accession number. And the accession number should be very unique so that it's never repeated. So typically we have a number like this, which begins with a year and followed by a 5-digit number. So that number is never repeated. Now, having this number, given this number, it's on your specimen, it's on the receipt which we get. Sometimes if you get electronic sort of requisitions, it could be on that requisition, and it could be on your manual register, or if you have it maintained online, it should be there. So this is this number by which you would follow up your specimens. As we all know, names in India are common, like Subba Reddy, Srinivasan, and so on. And you could never identify a tissue by its name of the patient alone. So we need to have two identifiers. In our hospital, when we receive the specimen, we have something called a UHID, the unique identity and the name of the patient. And when we receive it, we identify, we give the number, and then identify it after that with the name of the patient and the unique accession number that we give. The accession numbers are automatically generated so that there is no redundance of numbers, and we track cases with these accession numbers. Coming to this important area of fixatives, all of you, whether you like it or not, you must remember that the fixative that you use is 10% neutral buffered formalin. What does it mean? It should be 10%. It should be buffered. You have a mixture of salts to buffer it at a neutral pH, which is 7.2, and it's formalin. So you have to maintain the pH, you have to maintain the volume, should know what is cold ischemia time, how long does it one fix a specimen, and being exposed to formalin all the time and it's toxic, we also need to protect ourselves. So this is how we prepare 10% buffered formalin. The concentrated commercial formalin that you receive is a 40% weight by volume. We take that as equivalent to 100%, dilute it down to 10%, and add mixture of these salts, which is disodium hydrogen phosphate and sodium dihydrogen phosphate. By using a combination of these salts in a particular proportion, we make the buffered formalin, and for every can we make, we have the name and who prepared it and the date when prepared. It's important to fix the responsibility. So in our hospital, we even write the name of the person who has prepared it. So should anything go wrong, we know whom to ask. pH is not something a one-time affair. We need to record the pH every day of the formalin that we make. And we can use something, it's not like a very accurate pH, so paper could be used, but better to use one of these handheld pH meters, which can be validated against your glass electrode, your regular pH meter. So that this is something quite simple, very expensive, and can be used very accurately, reasonably accurately, to maintain your pH. How do you decide how long you fix the formalin? And that is determined by this coefficient of diffusibility of formalin. So this is the formula, and if you use that formula, you will find that formalin for every hour penetrates tissue about 4 millimeters. So what does that mean? It means that when you fix, you must cut your tissue not more than 5 millimeter thick when you fix, because formalin will penetrate from both sides and autolysis can set in and autolysis can destroy the tissue. Your formalin has fixed the tissue. So that is the idea why we cut. So there's a science behind it about why we cut it at about 5 millimeter width or so, slice the tissue. So the volume should be 10 times the volume of tissue, which you would be aware of. To a small container, sometimes surgeons, especially the new ones, would do large resections, and in their enthusiasm, and because fresh tissue is soft, it would go into very narrow-necked small containers where it would be very, very difficult to deliver. So it's our duty to educate our surgeon colleagues as well. Then you transfer it into a suitable large container after slicing or cutting open the lumen. And if the fixative happens to be blood-stained colored, you need to fix it. So here are 5 examples I have taken of tissue received in our lab. And you need to tell me and which one is the right one. So which is the right one? This is right, because this is, like I said, far too large, stuffed into a small container, inadequate, discolored. Here the tissue is in ice and not in formalin, and here again inadequate fixative. So this is very, very important. You must have enough fixative in the tissue. And formalin, you need to have these formalin meters which will record the formalin in your atmosphere. It should be less than 0.75. These meters are easily available, not too expensive, and we must have them installed in especially in our grossing area, so that we and all our residents, technicians are not exposed to this formalin. And we cut them not more than 5 millimeters. And you have these modern, very nice gross digital pathology stations available where you can record the photograph, record the gross, and it would be available integrated into your LIS. and you could have them at the time of reporting. But this is fancy. You can do this even without all this fancy equipment, but you need to follow the basic rules. Is there anything new in grossing? You can have laser-based devices to measure the exact thickness, or I have seen, especially in ocular pathology, people using vernier calipers to get accurate measurements. These are tools where you can put, so to get very parallel, uniform sections cut, you could use some of these. Having taken some, the representative bits, and if you do not gross them the same day, you're going to keep them because some more sections need to be taken. You can put them in the same container, adequate fixative, close it tightly so that the formalin doesn't leak. And I forgot to tell you that your grossing room should be adequately ventilated. You should have these very powerful exhausts which will drive away the fumes so that people stepping in will not even know that it is a grossing lab. What about the duration of fixation? These terms are something you need to know. Cold ischemia time, that is the time from the time the tissue is removed from the body, cut off from the blood supply, to the time that it is actually put in fixative. Now, this again has to be emphasized to your surgeon. True cut biopsy, small biopsy is usually not a problem because they take 5 minutes, 10 minutes, and it will be in formalin. It is these large specimens which need to be put in formalin immediately and transported to your lab so that you can cut them fresh. How long should you fix them? I told you they penetrate about 4 millimeters per hour, but the recommendation is you fix for a minimum of 6 hours. So do not be hurried by the request for a surgeon for an urgent report. The tissue comes at 4 o'clock. Don't be in a hurry to start the processing at 6 p.m. or so. Wait till the next morning and then you can start the processing. So 6 hours is the minimum and not very long because again, prolonged fixation in formalin can bleach the tissue. You will not get good hematoxylin staining. Your immunohistochemistry may not work. So 6 to 72 hours is what is prescribed for fixation. What happens if you don't follow that? Here is an example of a tissue where only the periphery has been fixed. So if you do IHCs, only the periphery gets stained and the center doesn't get stained. Similarly over here, imagine if you get something like this, half stained and half not stained, you will not know, is it positive, is it negative, and you can give a wrong report. Yet another example, a fibroid fixed for 2 hours and for 6 hours. You can see 2 hours, there's some fixation. It's not that it is autolyzed, but to get your right hematoxylin eosin colors, you must fix for at least for 6 hours so it is adequately fixed. Never compromise on your time to fixation. Yet another tissue, the same tissue, the outside has been fixed, so you get very nice morphology. The center not fixed, and it just is a blur of tissue. And no matter what you do, you will not get any details over here. And God forbid, if your tumor is here, you have missed the diagnosis completely. Again, after grossing, in all your excitement to give the report, to get the sections, you might just leave tissue drying. Never dry a tissue because if you dry it, then again, it's equivalent to not fixing it. It will just autolyze, it will become hard, and you will not get any morphology. This is what we don't do, but what surgeons do when they take a biopsy, like this is a lung biopsy, completely the forceps has been pressed, and you get this crash artifact over here. The morphology over here is completely altered. So novices need to be told, our colleagues who are doing these needle biopsies need to be told not to apply pressure to those tissues. Again, when you take bits for processing, make sure that you do not get very white tissue. This is almost 5-6 millimeters. When you take it through your processing agents, your alcohol, your xylene, it will never get processed. It should be 1 to 2 millimeters and just flat and parallel to each other. That is very important. Again, when your tissue in your cassette, in your enthusiasm, don't stuff tissue into 3-4 cassettes. Make sure it's optimal, neither too little nor too much, because if you stuff tissue like this, again, there is a danger that many of these bits may not get processed. And if your target lesion, if your tumor is in one of those tissues, you will again miss the diagnosis. If you are using some labels like this to write, which is fine, you can use a lead pencil, but the numbering should be very clear, so that finally when your block number, it should not be something where you don't know, is it 5, is it 6? And if you make a number, and if it happens to be, say, 2 kidney biopsies which are similar, there is no way after you process that you can tell one from another unless you do something like a DNA test on that sample. Again, residents, juniors who are grossing, be very sure that you wash the forceps between, so these extraneous tissues which belong to some other tissue don't get into it. This is in the block, so it's there on every section. And believe me, you can have a wrong diagnosis because a raw tissue from another organ has entered, another person has entered your specimen. Be very, very careful when you cross. If you have if you are in a hurry to process, and if you have processed tissue like this, then it is irretrievable. Again, I'm re-emphasizing the point that fixation is very, very crucial. You can't go back and fix it. It's gone forever. And this particular tissue, when it was cut, only the peripheral part was maintained. You could make out some morphology. The center was all cracked and cut, and no morphology was available over here. The same tissue again at the periphery, the immune stains worked, and at the center, there was no staining at all. So if you take a very thick section, only the periphery gets processed and the central area will not get processed. So having fixed the tissue, we take it through processing. And what is processing? It's a series of steps so that the tissue is made available for embedding in wax and for cutting. Now, this technology is probably almost 100 years old, and we're still following this process, though it involves some toxic chemicals, because we really have no other cheap and as effective a technique available to us. Okay, so we have the tissue processing, we have fixed it, now we have to process it. So we first need to dehydrate, which means remove the water, and we use graded alcohol for this, usually isopropyl alcohol. If you use ethyl, it's very good, but ethyl, as you all know, can be misused. So we don't have ethyl alcohol so easily available in our laboratory. Having dehydrated it, we remove the fat in it to clear the extracellular spaces. So we use xylene, or you can use something like toluidine or other things. And once you clear that, then the space which is cleared is infiltrated by paraffin wax, because paraffin wax is the final medium where you're going to embed your tissue. So this is the reason why we take it from formalin. We take it through alcohol, through xylene, and then finally through molten paraffin wax, and finally to paraffin wax. Now, what is the schedule of this processing? Should it be 4 hours? Should it be 12 hours? Should it be more than that? It all depends upon the number of blocks that you're going to process, the size of the blocks, and the urgency of report, how soon you want the report. For example, if you have something like a graft biopsy, a renal allograft biopsy, and you need it in 4 hours, and the tissue is very small, it's just a very tiny sliver of tissue, you can process it quite adequately in 4 hours, take it a wax block, get the sections out, and you can give a report in 5 to 6 hours. On the other hand, if you have a large hysterectomy, the report is not so urgent. You need to take multiple blocks, larger blocks, Then we typically put all those blocks together because that is efficient use of time and solution. And you do an overnight processing so that you don't waste time. You start the processing by 7 and by 7 in the morning, it is done. And all processors have more than one program, so you can have an overnight program and a small program and so on. But in all this, we need to intervene to change solutions. You need to know when to change solutions. Depending upon the solutions don't last forever. Every week, every couple of days, you have to have, depending upon how many blocks you process. Reagents should be of quality reagents. Only then is it well processed. You have to maintain a record of the change. And just like you don't stuff tissue into small capsules, you do not stuff those capsules into the processor. You should leave enough space so that there is solution available around those cassettes. So these tissue processors, you can have something like this, which sort of rotates. And here, the blocks in this carousel go from one container to another, depending on the program. In these closed sort of tissue processors, the paraffin blocks, the cassettes are stacked like this. You can have color coding of cassettes so that they know which ones are urgent, which ones are can be done late, and so on. You put them into a tank, and here the solution is pumped in and pumped out. So the cassettes remain stationary, and the solution is what comes from one container to another. Here, the cassettes go from one to the other. So that's the difference between the carousel type of processor and these closed processors. So what happens if the tissue does not have enough xylene, meaning the xylene clearing is not enough, or your xylene is not of good quality or very little time? You will find that the fat is not removed at all. The tissue remains very greasy and you will not get any sections at all. This is breast tissue, and you can imagine how horrible these sections are because it has not been cleared. Again, those areas which are not cleared will remain like holes. You will not get any tissue over there. This is a tissue which is under processed, so no section at all. You have the tissue, but there is no section available. If you do manage to get a section, then it will be opaque like this. Where it is not cleared, you will get completely, it will be opaque. So no matter what you do, you cannot. But you can reprocess, means you can reverse process. You can take it again in a backward direction through xylene, through alcohols, get it into water, and again process. It's not the best, but you can retrieve the tissue. Here is an example where the paraffin wax tank, the temperature, instead of being at about 60, just shot up to 100, and the tissue is virtually charred. Again, the whole thing will be sort of charred and will not get any details out there. Yet another example of tissue which is excessively heated and cut. You can see your whole IHC, the whole thing is a blur, a blob of tissue, a blob of cells. Sheets of cells where you can't make out, is it nuclear positivity, is it cytoplasmic membrane? Nothing is visible. So the effects of poor processing are you won't be able to get sections, you can't float them. The sections, even if they come, would be lifted off, so you will get spaces in your slide. And also, after that, if you do store the blocks, they will deteriorate very quickly. So what are the new things that we have in processing? Because formalin is toxic, there have been attempts by several researchers and companies to do something called formalin-free fixation. So this is a natural polymer, alginate, which has been used. But it's expensive, but it quickly disintegrates and more prone for artifacts. So it's really not the best, but in a research setting, it's possible to do it. Xylene, again, because it is toxic, it's an irritant to our skin, respiratory tract, and if exposed long enough, you can get headache and so on. So there are alternatives to xylene. So this is something called ultra clear, which has been developed from vegetable and mineral oils. Again, it's found to be suitable for very small tissues, for narrow tissues, for like true cut biopsies, but large, and it's good quality section. Staining is good, but for larger tissue, it's not as good as xylene, besides which it is quite expensive. So all of us work in laboratories where we need to maintain our costs to be able to afford our tests for the average patient. And so this becomes very expensive. People have used, there's a system marketed by Leica, xylene-free tissue processing, where the whole thing is done by isopropanol as an alternative to xylene. So there is ethanol dehydration, and then there's continued dehydration with isopropanol instead of xylene. But that again, it's not something I think which is being used large scale in regular labs, but this is something which you could attempt. The disadvantage, they say, in fetal CNS, which is a very rare tissue that we get, there is distortion and shrinkage, but otherwise it is a very good alternative to regular xylene. Tissue tech is another medium which has been promoted. And again, this is an alternative to xylene. It has a proprietary sort of, formula, and it's supposed to give good nuclear and cytoplasmic details. Microwave tissue processing, is it good? It does not use xylene and xylene free. So ideally, it should be a very good tissue processor. Clearing agents are not necessary. It uses dehydration. One step uses only isopropanol. It uses microwave. There are a few labs in India which use microwave processing, but most people believe that it really does not give a very good result, especially for tissue like breast tissue, for bloody samples. And in labs, it's very hard to have one set of processing for one tissue and another set of processing for another tissue. But if you are very environment conscious, microwave tissue processor is something you could standardize, but you need to work at it to get good sections. So having processed, we come to embedding. So this is our embedding station that we have. Basically, it's nothing but you have a paraffin tank on top, which maintains the temperature. And then you have a filter so that you don't get any kachara through your paraffin. And you embed and make blocks like this. And what is the heart of a good laboratory is the microtomy. You need to get good section, for which you need a good microtome, which is easy to get, meaning you buy it. But a passionate histotech is hard to come by. And so if you have someone who cuts sections good, who's really passionate about his work, you must do everything to retain him or her in your lab. So the microtomes can be either manual, which I feel are the best. You have semi-automated, where part of it, like just the trimming, can be semi-automated, or you have fully automated. But if you have a good technician, then a manual microtome is the best. And here is how we actually, this is a microtome where you get serial sections and the tissue is floated on to a water bath directly. Alternately, you can pick up the section and then float it on the water bath. So this is where you have a slide-like thing with water flowing on it, but you can have regular microtomes where you float it on the water bath over here. And here you adjust the temperature so that the wax just melts, and this is how you get the serial sections, and then you lift the serial sections with your glass slide. Okay, and having cut the section, you have to organize them. If you want serial sections, you have to organize them serially, number them so that there is no mistake again. Okay, are there improvements in microtomy? Yes, you have a laser microtome available, which is supposed to cut super thin sections, but I'm not aware of anybody using them for regular histopathology lab. Again, if you are mounting large sections, like a section of a lung, a whole section of a fetus, especially for museum techniques, you would have seen these things in museums, you need megatomes, big microtomes which cut large sections, thicker sections, but a section right across. Now, these are something you should be aware of because they are very, very common. If you have a thick section, it'll look like this. If your technician is in a very great hurry to cut the sections and cuts extra force, block trimmed too quickly, is when you get these holes. It's important for us pathologists to know so that we can identify what is the defect and tell them what the defect is. Remember that your technician will only respect you if you know his work at least a little bit. If you are ignorant, he's going to sit on your head and then you will never get good sections. Here is a section full of vertical striations, as it were, and this is because your knife used is a bad one, full of scratches or full of nicks. Again, a badly fixed or badly handled tissue can disrupt your section completely. Here is what is called chatter. It can be fine like this, or it can be large. Some people call it a Venetian blind sort of defect, and that can happen because your knife is not fixed to your microtome tight enough. The knife is rattling a bit. Sometimes with use, you will find that that knob gets loose and you need to tighten that to get good sections. Here is again, when they float the tissue and don't pick it up well, you will get defects like this. And again, the tissue is sort of compressed. You see, they're not spread out at all. And that is usually due to poor processing, or sometimes if the temperature of the water bath is too hot, it can become like this. Here is one where rest of the tissue is okay, and here alone there's some disruption, and that's because sometimes air bubbles get under the tissue when you are picking up the section. Similar one over here, it can cause, when the temperature of the water bath is too high, you can get artifacts like this. Here is one, poor quality sections, either because of bubbles or because part of your tissue is well processed, part of it is not so well processed. You will get thick and thin sections, and you must make sure that all these other extraneous particles don't get onto your slide. So having cut the section, you stain. You can do the stain manual or you can do it automated. Automated is nothing but the same manual program where you have a robotic arm where it goes from one stain to the other. So if your workload is small, manual staining is good enough. So this linear design, it can be one slide at a time or it can be in batches. So staining, what all should you look for? You should have a daily quality sheet where somebody is saying, yeah, your hematoxylin is okay, your eosin is okay. Are you regularly changing your solutions? And you must stick to protocols. The staining can never be like cooking, meaning no andas. You just add a little bit of salt, one handful of sugar, one pinch of whatever garam masala. It doesn't work that way. You have to tell your technician that they have to stick to the minute when they are doing the stain. Manual, it's anyway already programmed, but many of your special stains are manual, and you have to tell them that they cannot leave the staining area. They have to stick to time, stick to protocol if you have to get a good section. And remember, every time that you don't get a good section, either you're compromising on your diagnosis or you're asking the person to again stain, again do the test, which means there's a waste of time, there's a waste of energy, waste of your consumables, money. It's not easy. So they must get it right the first time. Cover slipper, most of us do a manual cover slipping, but you can also have these very nice automated machines available if your workload is high. So basically they have a suction like apparatus which picks up one cover slip at a time and the slide moves in, and then there is a tubing with your mountant over there. So the mountant gets added and it would come out in the bottom in this tray. It's a very nice piece of equipment to have if your workload is high. And finally, you mount it and label it, and that's ready for submitting. And even during submitting, it's a good policy which we discovered not very long ago, that if you have a stamp saying when the slide has been submitted, what time, what date, then the person reporting it will know that it's already 2 days since the slide has been submitted, I have not reported it, or you can keep a check on your turnaround time. So that is for submission. So this is what I have to say. I'm sorry if I went through it fast, but this is my last slide, after which we will go on to some questions. So we cannot sit back and say that the technicians will do their job. We need to take a leadership role in especially all the pre-analytics of the laboratory, of which, in my opinion, as I have told you, fixation is the most crucial. Regular monitoring, continuous education is very important, especially if you're getting samples from outside, or if you are sending your specimens out. You need to keep a check on the lab which is doing your test, and you need to constantly tell your surgeons, your other people who are sending your OT, that the fixation should be adequate, that you should be supplying the formalin pH should be maintained, and so on. And finally, since the microtomy is really the heart of a good histopath lab, microtomy is really an art. You must reward a good histotech and treat them like very special artists if you have to maintain a good lab. So with that, I have a couple of cases, and I think we can go on to the cases. Dr. Prabhu, should we do that, or did I go through it very fast?
We can go to some discussion,
and then I can take some questions if necessary from the audience.
Yes, questions will keep at the end, ma'am.
So this is going to be like a fun thing. I have with me the names of 5 students who have volunteered. So basically, the question is, there is a defect in technique in each of the following slides that I'm going to show you. What you need to do is identify the defect and say, can it be corrected? Is it possible? And how do you correct it? Okay. So we go to the first one, which is this. So here is a tissue on the left and here is a tissue on the right. And the question is simple. I think we will have Ria. Ria, is she there?
Yes, ma'am. Yes, ma'am.
Okay. So we have Ria here. Ria is from which medical college? I forget.
Ma'am, Muzaffarnagar Medical College.
Sorry?
Muzaffarnagar Medical College.
Muzaffarnagar Medical College. And she will tell us, she'll take the first 4 or 5 slides. Oh, this is, what is the difference between the specimen over here and the specimen over here? Left
the
one.
first picture of specimen is not fixed. Yes, ma'am.
Yeah, exactly. And the right?
It's, ma'am, section.
Yeah, correct. So this is serial sections from a specimen where we want to sample the entire tissue. It could be something like a radical prostatectomy or not. But you see over here that you must appreciate the change in color which happens with formalin. Okay. And this is something where very fresh, very red, very hemorrhagic. You certainly cannot take these sections directly for processing. You need to slice them at 5 millimeters, put them in formalin overnight. The next day you take it out and then you can annotate them. You can take a picture of them and then say which areas you're taking bits from, so that later when you're reporting, you know exactly which area is being which area it represented. And these are slices which are completely well fixed, and these are ready for processing. So with experience, you will know when the tissue is right to get into the processor. Remember the window of 6 to 72 hours. Yeah. So with this tissue, I'll have one more question for you. This tissue is red and hemorrhagic, maybe a congested spleen or liver, I don't know. And you put it in non-buffered formalin. What is the artifact that you will get on your sections? Why is it that we are harping on this buffered? I forgot to tell you. I should have told you. Now this is the time when I should tell you. Why is it that? Yeah. Any idea? Wow. What artifact? you will get. Any of the others can say? Divish. So when you have so much of hemorrhage, the important artifact that you will get is formalin pigment. Formalin pigment happens at acidic pH and in formalin. So this is one of the main reasons, because we don't want formalin pigment, because it will really interfere in your tissue. So if you look at hemorrhagic sections of say a spleen or anywhere else, and you find this brown pigment just lying there, you will know that it's formalin pigment, and you can say that that lab has not probably used formalin. So very, very important that whatever else you may forget, please don't forget buffered formalin and 10% neutral buffered formalin, and make sure that that is used no matter whether your tissue is or not. It's a regular hysterectomy, regular gallbladder. It's a very valuable tool. For all specimens, you must use neutral buffered formalin. So we go to the next. Okay, this is something I told you. So if you've listened, I think you should be able to identify why is there a heterogeneous staining in the picture below. What do you think is the defect, Ria?
Ma'am, it could be due to drying edge effect.
Drying edge effect, very good. It could be. Assuming that this is not, this doesn't look like drying, right? So what has happened?
It is stained at the periphery, but not at the center.
Exactly. Why is it that so? Drying definitely is one. Anything else? Yeah, there are some answers coming in also. Poor fixation, excellent. This is poor fixation also. Poor fixation, poor processing. If you get very thick sections, you will find that only the periphery sort of stains, and in the center you will just have, you wasted this whole lot of reagent time only for you to look at the periphery and try and come to a conclusion. That is unfair. Unfair on the patient who has sort of put their faith in you, expecting you to give the right diagnosis. And because you have not been careful in your fixation, you have landed up in tissue like this. And no matter what you do, you send it to another place, you send it to Tata Memorial, they will also have the same problem, because your tissue is not well fixed. Here, this is the same tissue stained with the same protocol. Here it is different. Here it's much better. What is the difference?
Difference in the section thickness.
It could be section thickness will actually not will affect the processing. So you will not get this uniform staining at all. So this is something else. Correct. I think there are people who are answering. This is a fixation time. I think this is the same thing which time of fixation. That's correct. This is the time of fixation. If you get tissue very quickly into the processor and you stain, you will find that your hematoxylin will be dull, your eosin may not stain. So to get your adequate hematoxylin and eosin, you must give that time of 6 to 72 hours. One of the reasons we mentioned that 6 to 72 hours is that you get the right hematoxylin and eosin stain. So this is the time that you have given for fixation. Here, what is a defect? What tissue do you think this is? It's so yellow.
Adipose tissue.
Yeah, it is some fatty adipose tissue. Exactly. And why is there no tissue? Why is there no section at all? You should have got adipocytes here, right? But in the section, there is no adipocyte. So what has happened? Yeah. What is the defect, Ria? No, it will be like a multiple choice. Is it?
Ma'am, it's due to poor clearing.
It's due to poor clearing. Exactly. Tissue may have been fixed, but if it does not go through adequate clearing agent, which is usually we use xylene, we can use chloroform also. Chloroform also gives excellent clearing, except that it is little more toxic. So we've stopped using chloroform. So if it does not go through enough time in your clearing agent, this is how the tissue will be. And here, can you retrieve this? Can it be rectified?
Ma'am, by reprocessing.
Yeah, how will you reprocess? Supposing it's a very valuable tissue. Yeah, I think
Yes,
there are
ma'am.
some answers coming in. What would you do? Because it's not something theoretical question, it's practical. This is the only biopsy that you have of a very valuable tissue, and it has been spoiled because it has not been cleared properly. You can reverse process, which means you have to go from xylene, go back to xylene, and then go back in descending orders of alcohol. You first start with absolute alcohol, then 90, then 80, then get into water. Once it's in water, go back to formalin, keep it in formalin for some time, and process it again. It's not going to be as good as if it had been done well the first time, but nevertheless, you will be able to get some morphology and you may be able to make a diagnosis. So this is called reverse processing. What is the defect over here? We can go to Divesh now. Divesh, I know, is from Nepal, right?
Yes, ma'am.
Which medical college?
Decalcification Institute of Health Sciences.
Okay. So Divesh, what do you think is the defect over here when only the periphery is sort of seems processed and the central, you can see how horrible it's like soft, mushy, nothing over there, and you're getting a cracked section like that. So what is the problem?
The periphery has been fixed, but
So,
and
yeah,
processed well.
Yeah, exactly. So very good. So the periphery has been fixed and the central is so poorly fixed. In fact, it's autolyzed, the center. So is this reversible? Do you think this is probably not reversible? Because you have damaged the tissue completely, which is why we, in the best interest of the patient, should educate our surgeons that if the tissue is not going to come to us immediately, they should slice it. You should tell them how to slice it, what plane to slice it, whether it go antero-posterior, lateral, whatever you want. Tell them how to cut, for example, a hysterectomy. The endometrium would be invariably be autolyzed, and you will never get any details of endometrium if your hysterectomy is not cut on time and fixed on time. Because the endometrium is a tissue which is very, very prone to autolysis. And and from the same section, if you do again IHC, the periphery is very well stained, but you can see the central area is completely, you don't know whether it's positive, is it membrane, is it weak positive, but this is the same cells. That is the importance of fixation. Yeah. So what is the difference between these two blocks? It's the same tissue.
The section on the left block, the center portion has been kind of autolyzed.
Yeah. You can see the central portion, it's sort of autolyzed or poorly fixed or whatever. So there is no, it would give very poor. So which one will you take for ER-PR study?
The right block.
The right block, correct. So ER-PR, HER2, there are ASCO-CAP guidelines that fixation should be from 6 to 72 hours because ER-PR is such an important test. You're going to determine what treatment you're going to give the patient, how the patient is you're going to prognosticate depending on those markers. And so it is our duty as laboratory personnel to make sure that the tissue is fixed and you adequately, neither too long nor too short, and you take the right tissue for your ER-PR testing. And here, what is the defect?
The paraffin is too hot.
The paraffin is too hot. Now, these are things I've shown you. So you can see that the paraffin has been so hot that again, it will completely destroy the tissue. When when these sort of things happen in your lab, in a sense, it's a crime that you are committing in the lab. because the tissue is given into, and it's in your custody so that you can process it well and give the right diagnosis. Or even if you can't make a diagnosis, the tissue is preserved so that somebody, some other expert can study it and give a report. But if you give something like this, then no matter expert or no expert, you cannot give a diagnosis. So that is the reason why we monitor, amongst other things, we also monitor temperatures, especially temperatures where you are embedding, that your wax is not overheated. So this is due to an increase in temperature of your tissue. Okay, tell me. Here are two tissue sections and there are contaminants. Tell me, what is a contaminant? What is a contaminant on the left? What is a contaminant on the right?
On the left.
Yeah, I mean, I agree. These sections are not great. These pictures are a little blurred. I can tell you that this is, say, from a leiomyoma or something. These are smooth muscle. Yeah. So what is this?
The tissue on the bottom.
Yeah. What is it? Tissue on the bottom. It's an extraneous tissue. It's a floater. Okay.
Yes.
So this has come from some other tissue. And where do you think it has come from? Supposing there are serial sections. And then you know what are serial sections, right?
Yes, yes, ma'am.
On one slide, you take multiple sections. And on one section, you have this. Other sections, you do not have it. How do you think this tissue has reached this section, this slide?
From the
At
water
what
bath.
level?
From the water bath.
From the water bath, exactly. Because in the water bath, you're cutting one section, floating it, and then you're cutting the next one. So between blocks, between one block and another block, it is imperative that the water bath is cleaned. Means, how do you clean? How do you think they clean the water bath? Do they keep changing that water between blocks or do they do something else?
In our institution, they wrap a piece of tissue paper.
Correct.
Around a holder or a brush, and they just skim the.
Correct. Exactly.
Layer.
You just skim the surface of the water bath with a tissue paper so that all these small floaters, they're tiny ones, you know, and then to move it, or to make it, you know, a little less expensive, we actually use just newspaper. We just use newspaper between us and we just clean the surface of the water bath. Very, very important, because once it enters the tissue, you can make a wrong diagnosis. Supposing this floater is present in every section, then where do you think the defect is?
During grossing.
Yeah, it is either during grossing or during embedding, you know.
Yes.
When you're embedding, you're taking subsequent things and inadvertently you take one from one tissue which doesn't belong and put. It's a very, very serious error, because often we can make out, you know, because it's so different. For example, if a prostate comes in a breast tissue or something, you know that it is a floater or it's a contaminant in the block. But sometimes if it's the same tissue, you can make serious errors. What is the contaminant on the right?
The small red.
Yeah, these.
Yeah.
What are they? What do you think they are? These?
Cannot make out properly, ma'am.
Yeah, but what do you think they are? Yeah, I think people are saying they are squamous cells.
Okay.
Yeah, they are probably all anucleate also. Anucleate squames. From where have they come? What is the source?
It could be the technician might have coughed or sneezed.
That when you cough or sneeze, I'll show you the next one. That will be even more. But here it's usually, especially hands. When you pick up a slide, very important to tell your technicians, handle the slide from the edges. Don't put your hand in the center, because you don't realize how millions of squamous cells are being shed off from your hand and they will just get onto the slide. Okay, very important that they clean the slide and it is handled by the edges. Or if some people still use egg albumin as to as an adhesive. So if you use egg albumin as an adhesive, it's not the best adhesive because it's thick and thin. It gives you a background pink. And importantly, all those slides will have plenty of squamous cells. So the better, what do you think is a better adhesive? You need something for the section to hold on to the slide. So what do you think? What is your thought about adhesives?
Lysine.
Lysine, glycine, maybe you can. But what we use is we use glycerol, which we make a solution of, and you put it in the water bath, and that will act as an adhesive. Or if you are in a rich lab and you can afford, then especially for immunohistochemistry, we use charge slides, which have a positive and a negative charge, so that those charge slides, by virtue of their charge, the section will get adhered to the slide completely. Okay, so that's the way, and that way, by using those methods, you don't have any of these squamous cells. This is what is called a sneeze effect. When your technician or anybody, before the cover slip is mounted, you just sneeze on the section while it is being picked up before staining, so that all these, it almost looks like a pap smear on a section. Yeah. So this is to be avoided. Okay. Now, one last question for you. What is this artifact? This artifact at the periphery. This is a tissue, very well preserved. Yeah.
Shattered. The tissue has been shattered. Maybe.
No. What is it? Many answers coming up on the chat.
Crushing.
This is crush. This is crush artifact. You must learn to recognize this and never try and make a diagnosis based on these crush. Crush, because the tissue is so fragile, the cells are so fragile. When they are picked up, the edges of these slides will get crushed. Is it helpful in diagnosis? Is there any condition that you know where, by nature, by virtue of the cells being like that, they are prone to crush, and in fact, it helps you in the diagnosis?
Yes, ma'am. Small cell carcinoma.
Yeah. Small cell carcinoma, even many lymphoma, specifically small cell carcinoma. Yeah.
Yes.
Small cell carcinoma, many are typing SCC, which is, I'm assuming it's squamous small cell carcinoma, but SCC is also a squamous cell carcinoma. So avoid using too many short forms. What is this artifact?
Micro.
It's due to the knife cuts. Yeah, when your knife has full of these small, but the edge of the knife has a lot of
implants.
Yeah. When the edge of your knife is blunt, then it can have all these very coarse sort of lines across. So what would you tell your technician? Simple.
To change the blades.
Change the blade if you are using disposable blades. But I don't know whether there are labs which still use non-disposable blades where there is stropping and honing. You might be asked these for your exams. How do you strop and how do you hone? There are different methods for sharpening the knife. Stropping followed by honing of this knife. And there, how will you check is there any way that you can check the edge of the blade? What can you do? There are many ways by which you can check if the edge of your blade is sharp. Tell me one way.
I don't know.
Yeah. So one easy way by which we do is put it under the microscope. Okay. Under your scanner view, and the edge of the blade, you get it into focus, and it should be an extremely sharp, thin line. So any nicks in the knife will be magnified and you can easily make out. Yeah. So that is how you make sure. And if even your disposable blades are like that, many of them are like that, then you should call your vendor and ask them to change. Okay. We'll go to the next person, Deepika. Deepika is from Mallareddy Hospital. So Deepika, what is this artifact?
Also chatter.
Huh?
Chatter. Chatter from Venetian lab.
Yeah, a chatter effect. And why is it mainly? Why is it due to? It's a little different from this. Yeah, where you actually get lines across the tissue.
Yes.
Here you don't get lines. So what is it?
For cutting the microtomy.
Yeah, but what about the microtome? What should you tell your technician?
Also sharpening the knife.
Sorry?
Sharpening the knife and the thickness of the
More
tissue.
than that, this is because they have not tightened the holder. When your knife is sort of moving a bit and it's not held firm, that is when you get this effect. Okay. So if your microtome is a little old and your tightening screw, the knife is not tight enough, when the clamp is not tight enough, then you will find that these. So mainly you must check the clamp for your knife, and also of course your processing, whether the tissue has become too hard. If the tissue is extra, if your tissue is in xylene for a very long time, then it will become very hard. And once it's very hard, you will not be able to cut and you will get this chattering effect. What is this? When does this happen?
When
Sorry?
the sections are taken very thin.
No. This happens because when they are doing a trimming of the block. When they're trimming of the block and your technician, and your technician is in too much of a hurry, and they do it very fast. When they do it very fast, then these holes start appearing in your section. So this is mainly because when the technician is cutting your sections very fast. There are other reasons also, but mainly this would be the main reason. Then you must tell them you cool your block adequately and go slow and cut a slower and more uniform section and you will get it. Okay, this? Where does this, what is this due to? What are all these?
There are folds in the section.
Folds. And where do exactly folds? Folding of tissue.
After trimming, if they're not spreading the ribbon shapes.
Yeah, not trimming. When they're after cutting.
Trimming.
Trim is initially when you want to expose the whole surface. That is called trimming. And then they cut the final section, which is at 2 microns, 3 microns, that. And then they float it out on a water bath. If your temperature of your water bath is very low, then the wax does not melt, the tissue does not spread. Okay. And some tissue like this cartilage are more prone to these folds. So this is due to spreading of the tissue. Okay. In the water bath. That is the time when you will get these folds. And okay. One last question for you. What stain is this? Anybody else? Vivek? What stain is this?
PAS stain.
PS. Yeah. PS stands for?
Periodic acid shift.
Periodic shift.
Periodic acid shift.
Acid shift.
Correct. So how do you know it's periodic acid? Because what color is positive in PS?
Yes.
Magenta.
Magenta.
Yeah, everything is pink, but you must look for a magenta color. Okay, and these tubular basement membranes are magenta. Can you see? That's a magenta. So coming back to this question, is there's a left and the right? So Deepika, which is the one with artifacts? Is this the left or the right one? Vivek?
The right side.
Right is artifact, correct. And what is it? What is the artifact?
Shrinkage.
Shrinkage. And why has it occurred? Exactly. Why has it occurred?
More of dehydration, excessive dehydration.
More expansion in the water bath.
No. This is you must remember that this is the earliest change of autolysis which occurs in a kidney. That the tissue basement membrane gets separated from this. So once you know this, then you know that there is some artifact, there's some delay in fixation, which means that there is a delay from the time the tissue has been taken out of the body to the time it has been put in formalin. That is, they left the tissue around for some time and then they put it. So you can catch your nephrologist and you can tell them this is the artifact, and you can see that once there is a delay in fixation, this is the same staining protocol, and you can see how crisp the staining is, the nuclear, the cytoplasmic, all of it, and here it's also blurred. Maybe you can still make a diagnosis, but you can see how different the quality of sections are just for fixation. I show this to you just to say that as important as the fixation is the cold ischemia time, the time from when the tissue is removed to the time that it gets on to the fixator. These are two consecutive sections from the same block, means they're process, fix, process, same way. Yet the staining over here is like this, over here is like this. So what do you think has gone wrong on the left? The left is worse, right? The right is better. What has gone wrong with the left? Vivek?
Ma'am, the left one is more thick section.
You got a point. It may be thick. Supposing it's not thick, then where do you think the mistake? Yeah, I think people are getting it right. On the one is a thick section, but more importantly,
paraffin wax temperature.
Yeah, exactly. Not where the temperature paraffin wax doesn't come over here. You have already embedded it. Remember, it is all post embedding, post cutting, or post sectioning. So the sections, assume that the sections are stained and they are stained. So whatever artifact is come during the staining or after the staining, right? So during the staining, again, it could look very similar to your improper processing. Remember, your improper processing was like this. Again, this is because there is probably a layer of wax over here. Remember that the sections have a layer of wax around, and that wax has to be removed, and that's the first step in staining, when you remove the wax with xylene. So when you do not allow the wax, when you do not keep it enough time in xylene, or your xylene has been used so much that it's full of wax and you cannot remove the wax any longer, you should change the container of the xylene and take it again through deparaffinization. When it's not deparaffinized well, that's when you get this artifact. Here, what is the artifact? Okay, I'll give you a thing. Is it during fixation? Is it during processing? Is it during cutting? Or is it during staining? Multiple choice.
Fixation.
Fixation, yes. What do you think has gone wrong? Why do you think there are so many places, like abnormal sort of,
Overfixed?
No, not overfixed. So this was a case where we actually did a lot of autolysis freezing. Yeah, I don't know who said freezing. Anita, that's correct. I mean, I'm reading what people are writing on the thing. This is freezing. Sometimes the surgeon does the biopsies and puts it in formalin, but in his enthusiasm just gives it to the nurse and tells the nurse, and this is actually what happened to the tissue. Tells the nurse, you keep it in the fridge and we're going to send it only tomorrow. And in her enthusiasm, the nurse thinks, okay, keeping it in the freezer is the best thing for this tissue, and that's what happened. So the whole thing froze. The formalin froze, the tissue froze, and then by the time you have no idea, because by the time it reaches you, it's at room temperature, and it is in formalin, and it is in buffered formalin, everything, and you have processed it very well. And so when you go back and when you get artifacts like this, remember, it could be because your tissue has been inadvertently frozen by a very enthusiastic person. And these are actually all the ice crystal artifacts. The ice crystals get into the tissue, and then when the tissue thaws, those spaces get left behind. It's a very, very bad artifact, something which you cannot do anything about. You cannot retrieve the tissue and you cannot do anything. So fixation is more than 10% neutral buffer formalin. It has to be at the right temperature, right time, everything. Very, very crucial. Here, very similar.
Yes. It is also fixation
No,
Uh,
these, look at the
clearing,
question. These are two consecutive sections from the same block. Means they're processed identically. You're getting one section like this, and you've stained the next section, it's like this. What's gone wrong? And these are actually sections which I actually, did it to get these. The last time I gave this lecture, I actually did some of these experiments to get. So here, what has happened? So in tissue,
about temperature.
In staining, you don't have any temperature. You usually do it at room temperature. So there's no question of temperature. So it should be either the wax has not been removed. I showed you, it looks very much like that. Or at the end of staining, you have a step called clearing, xylene. Yeah.
Yes,
After you take it through water, you have a step called clearing, dehydration and clearing. So when you don't dehydrate and clear at the end, you have stained, you finished your eosin, you come up to the last stage, and you have not gone through your final steps of dehydration, a dip in xylene before you mount. If you don't take care of that step, then you will get this blue. Important, because then what you can do, you just need to remove the cover slip, destain it by using acid alcohol, and stain it again, and you will get back. So the important thing about identifying these artifacts is also to know, is it reversible, not reversible, and how you can set it right. Here, what is a defect? These were actually sections that we got from outside. These are actual day-to-day problems. What do you think is the problem here? This is supposed to be a sections true cut biopsy of the prostate. And these sections were sent to us, and we looked at it and we couldn't make out anything at all. Yeah, there are some acini, and it was actually, I don't remember what it was reported as, but we couldn't make out anything under the microscope. So what do you think has gone wrong?
Probably the tissue is hard. That's why the
no tissue. That could be. It could be that.
And
yeah, this
handling.
No, actually the tissue had been handled well, had been processed well, but the whole thing was in the section. The sections are far too thick. These are very thick sections. Okay, so sections ideal should be 2-3 microns. Okay, these were cut, I don't know, maybe at 4-5, and the staining also. There was no differentiation of eosin and hematoxylin. Everything was a uniform purple. So all we did was the same block, we cut thin sections, and this is how it looked. These are exactly the same block, and you can see that. You can see the smooth muscle, you can see the acini, you can even see some microacini here. You can zoom in here and see whether it's adenocarcinoma or not. Okay, so these are identical. You can hardly believe that these are the same. Okay, so just attention, need to have a good microtome, even better technician, and have the right protocol for staining, and we have made the diagnosis. Remember that 90% of your diagnosis anybody can make. And the reason you make differences is because there are these artifacts in your sections. Okay, here is the one. Why are the details of morphology not made out at all? It's all one. And this is with your best technician handling it, with your regular processing, staining, and yet you got something like this. What do you think happened to this tissue? Okay, is it prior to fixation, processing, or staining?
It is prior to fixation, I think autolysis.
Yeah, correct. So this is not a staining artifact. This is actually, if you look carefully, everything is just, like just a mass of cells, and you can't make out any details. And you have to get used to how autolyzed tissue actually look. You can do that experiment very easily. When you get a tissue, part of it which you think is not important, leave it out for some time, then process it, and then you will get. So this was a tissue which was completely autolyzed. This was actually a post-mortem sample, and that's how we know for sure that this was an autolyzed sample. So again, autolyzed tissue will look like this and cannot be retrieved. Irretrievable errors. Here, what is a defect? Okay, let's go to the last person, Arpita. Sorry. Arpita, is she here? Yeah,
Yes, ma'am.
yes, Arpita, welcome. So what do you think is the defect here?
Ma'am, there's a horizontal line running across.
Oh, that's right. Very good. There's a nick over here. There's a nick in the knife. I'm glad you were able to. But why is it looking like this? Some brown here. It's not a good section, right?
Yes, ma'am.
What do you think is here?
Ma'am, formalin pigment maybe.
You can mistake it for formalin pigment, but this is not formalin. But you can't even see. I'm telling you that you're getting these black, brown here everywhere, and you are not seeing thing. Thick section, somebody said, no, actually the section was quite good. I sort of purposely made this artifact so that it is what I'm going to tell you it is. So this is where you don't cover slip it properly, okay? Remember that in cover slipping, you take it through xylene, and then if the tissue sort of dries up, and then you put the mounting medium. But if there is water in the tissue, or if it's not dehydrated properly, then you will get this blurred sort of image. And if you keep it under, the easiest way by which you can make out that the tissue is not cover slipped well, if you just keep it against the light, it should be transparent. It should be absolutely clear. You just lift up the slide, look at it against the light, and if it's opaque, then sure enough, it will be a cover slipping problem. Cover slipping or the dehydration problem I showed you in the section. Okay, so this is improper cover slipping, and that's how it looks. And this, why is it like this? Opaque, somewhere clear. You can somehow make out the details in between. But where you want to see it continuously, one little opaque sort of thing comes. What do you think happens here?
Ma'am, crush artifact or...
What artifact?
Crush artifact.
Crush, nahin. Crush is different. This is not crushed. And crush can't happen like this. The whole area will get crushed. Yeah? Yeah. It's people said deparaffinization, that's possible. Actually, here's a problem. It's mainly due to your cover slipping. Okay. Either the DPX is thick and thin, so you get this. But this, in fact, was when you use an automated cover slipper. Sometimes it picks up the cover slip and it drops it on the slide. And sometimes it will pick up two cover slippers. And by mistake, even your technician, when they pick up a cover slip, if they pick up two cover slips and they put it like that, it's basically a defect in cover slipping. So two cover slips at a time. And so that has made the slide like this. Yeah. And easiest way, like I said, is just hold it against the light and it'll be opaque. Yeah. So with that, I think that is the last I had for you. I didn't want to keep you too long. So as is our pathology, so is our practice. Yeah. As was our technique, so was our pathology. And as is our pathology, so is our practice. So techniques, very, very important to learn, to understand, to identify, and to rectify. Okay, thank you very much. Thank you, special thank you to all the students who so eagerly participated. I do hope it was good for you and you'll go back and read up some more. Yeah, thank you.
Thank you, ma'am.
We have some questions in chat box.
Yeah, sure.
Yeah, the first question is, what is the optimum temperature of water bath?
Optimum temperature of water bath is supposed to be the water bath where your temperature, where your wax just melts. Okay, so I think we keep our water bath around 50-60 degrees. We keep our water bath pretty hot, so that it just melts the wax and it doesn't dissolve the wax completely. So, or maybe a little less, 45 maybe is what we have our water bath. So that you need to check your temperature of your melting point of your wax and keep that water bath temperature a little lower than that, about 5-10 degrees lower than that. That's how. So it just begins to melt, maybe 50 degrees. Yeah.
There's one more question, ma'am. In fixation of postmortem specimens, are the concentration of fixative and duration of fixation the same as usual?
Absolutely. I don't see any reason why postmortems need to be fixed differently. It's a large specimen. So again, you have to slice it and put it in adequate formalin, 10 times the volume, slice tissue 5 millimeters apart, keep it enough, keep it overnight for fixation, and then you can cross it. I don't think it's any different from your regular surgical samples.
That's all, ma'am. I don't see any other questions.
I think there's some people who have raised their hands. So how do they come on?
They're just complimenting and thanking you, Dr. Sandata.
Oh, that's
excellent. Yes. There are a lot of students
That's
here. After a long time, we had 255 students today, and because we generally have 180, 170. I think excellent presentation, Dr. Sandata. It could be better.
I do.
We have one more last question, ma'am.
Yeah.
What can be the best or ideal thickness for sectioning?
Sorry, I didn't hear.
Your voice is breaking clear now.
What can be the best or ideal thickness for sectioning?
Ideal thickness for sectioning? Yeah, that's a good question. We try and get all our sections like at about 3 microns. But for tissues where you require extra thin sections, especially renal biopsies, we get them cut at 2 microns. There are centers abroad which cut renal biopsies at even 1 micron, but I think that's very difficult. The tissue breaks up too much. So we get it at about 2 microns.